Well, welcome everybody to ICMDA webinars. I'm Dr. Peter Saunders, the CEO of the International Christian Medical and Dental Association. And this is our 18th webinar on various aspects of COVID being broadcast around the world. We expect to have people from over 50 countries tuning in today, almost all doctors and dentists. And our subject for today is reopening church safely, effectively, and biblically. And we're very privileged to have the Reverend Dr. Stephen Coe speaking to us on that. Now, before I introduce Stephen and hand over to him, just a few housekeeping notices. ICMDA brings together over 80 national groups around the world of Christian doctors and dentists. If you've not been with us before, and you'll find much more information about us on our website at icmda.net. Where you'll find also information about the webinar series, and you can watch past webinars there. Dr. Coe is going to speak for about half an hour, and then after that we will have a Q&A, and you can put your questions into the Q&A box at the bottom. You'll see along the bottom of your screen there's a Q&A. Put your questions in there, not into chat, and then you can see what else is being asked, and you can upvote other people's questions so that they're more likely to be asked. You can put those in any time from now on and during the Q&A later. Today's webinar is going to be translated for the first time ever into 7 different languages. So listen very carefully now when I tell you how that's going to work. If you want to hear it in another language, then you need to click the interpretation button at the bottom. That's the little picture of the globe, and if you click on that, it will bring up the languages, the choice of 7. Now, there are a couple of complications here. If you want to listen in Russian, in Spanish, in French, in Portuguese, or in Mandarin, then it's no problem. You just click the name of that language and you will be able to hear it in that language. You'll still see Dr. Coe speaking. But if you're wanting to hear it in Arabic, then I'm afraid Zoom doesn't yet have an Arabic tab, so you click the German tab. So Arabic speakers click German and you'll hear it in Arabic. And if you're from Indonesia and you'd like to hear it in Bahasa, then you click the Korean tab, because there's no Bahasa tab yet. So we're ahead of Zoom on this technology. So 7 languages: Russian, Arabic, Mandarin, Portuguese, French, Spanish, and Bahasa available today. So let me now introduce Dr. Stephen Coe, who will be speaking to us shortly. The Reverend Stephen Coe serves as the senior pastor of the New York Chinese Alliance Church in New York City, and his healthcare specialties, he's doubly qualified, include pediatrics, preventive medicine, and public health, and he's currently the adjunct professor at Alliance Theological Seminary. Previously, he served as a global health professor at Boston University and a medical officer for the Centers for Disease Control and Prevention, that's the CDC. And he's worked extensively in Africa and Southeast Asia on diseases of epidemic potential, helping low and middle income countries implement their national public health programs. Writing at the intersection of faith, medicine, and public health is a real passion for him. So, Stephen, we're delighted to have you today to speak to us on reopening church safely, effectively, and biblically. Over to you.
Well, thank you for the kind introduction, Dr. Saunders. Before I begin, I'd like to make a quick correction to a virtual introduction done by CMDA CEO, Dr. Mike Chupp. In an email yesterday, Dr. Chupp promoted me to the position of CDC director. While I'm flattered by this promotion, I never served in this capacity and likely never will, since it is appointed by the president. Well, welcome ICMDA and CMDA members. It's a pleasure to be with you today. We'll be talking about an important yet sometimes contentious topic, reopening the church safely, effectively, and biblically. If done cautiously and with wisdom, it can be a source of tremendous encouragement to our congregations. Yet, if we reopen our doors nonchalantly, without purposeful prayer and a well thought out strategy, we can endanger the lives of our congregants while having disastrous consequences on our churches. It remains a highly polarizing issue. You need only scan the headlines to see that it's true. With John MacArthur's recent decision to reopen his megachurch in California, we see two sides of the coin. One title reads, How John MacArthur Loves the Bible, but Not His Neighbor, while another title reads, John MacArthur Defends Religious Liberty. So how do we reopen the church safely? During their training, medical students take the Hippocratic Oath. One of its promises is to do no harm. Though pastors focus on spiritual healing a majority of the time, we should adopt the original Greek saying for physicians as well, ensuring the safety of our congregations. This includes understanding risk for transmission and concomitant infection control and prevention practices. Whenever we look at disease, especially epidemics and pandemics, we should understand the overall risk factors for our congregations. Let's face it, most pastors have been overwhelmed by COVID-19, a new norm for online ministry, months of lockdown, quarantine, and isolation, and now the prospect of reopening the church with so many unknowns. Therefore, I'd like to simplify the overall risks into 4 tiers within a pyramid. At the very base of this pyramid is coronavirus activity in the community. The infection rate around churches underlies all other risks. Next is organizational capacity to ensure a safe environment for brothers and sisters. The extent to which you develop and implement an effective plan to mitigate other risks. Third is ministry-related risk factors. All church activities are not created equal. Sanctuary worship is much different than an alpha small group over dinner. Finally, at the top of the pyramid, every individual and family has unique characteristics that either increase or decrease their risk. Coronavirus activity in your community is a barometer for all other risks and foreshadows decisions made on local, state, and national levels in regards to mitigation. This graph depicts the statewide infection rate in Florida over time. It's important to have an idea of the incidence or number of coronavirus infections over a specific time in a particular area. Active outbreaks within a local community present increased risk of disease transmission. Though New York City was the epicenter of the pandemic in the United States for a season, the current situation in New York City is much different from that in Florida and Texas. The public health decisions of governors are tempered by their ability to obtain real-time information on active outbreaks as well as hospitalization rates. Next, organizational capacity and operational strategy are crucial to maintaining a safe environment for congregants. There are wonderful resources to help in the process of writing guidelines for churches. On the left side is the Guide to Reopening Church Services from Wheaton College's Humanitarian Disaster Institute. And on the right side is CMDA's newly minted recommendations for gathering during COVID-19. Some potential questions to ponder include the following. Do you have a thoughtful plan to ensure the safety of participating congregants? What infection control and prevention practices will be adopted during specific church ministries? What strategies will be implemented to support healthy operations with the church, like staff leave, absenteeism, and cross-training? How will you then communicate to the congregation and to staff? These and other nuanced questions should be carefully considered. The next tier of the pyramid is ministry-related risk factors. Every church activity is unique in the way congregants participate and interact with one another. Therefore, each ministry offers differing levels of risk for participation. Let's look at some of these considerations. Is the patient symptomatic with fever, cough, and chills? If so, it's wise to advise them to rest at home. Yet, even if you accurately screen patients, more than 30% of transmission is from asymptomatic or pre-symptomatic individuals. Does the ministry involve increased frequency and duration of interactions? Other risk factors include the following. Ministries that yield more aerosols and respiratory droplets, like loud singing, thunderous preaching, and strenuous exercise. Activities that involve physical contact with others or shared items, like hugging, handshakes, and passing around communion elements. And programs in confined spaces without adequate ventilation. It's safer to be in a large outdoor field than in a tight basement with stale air. This is a dispersion diagram depicting typical aerosols released from a cough. Studies have shown that small aerosols in poorly ventilated areas can stay airborne for several hours. On the other hand, heavier respiratory droplets typically fall to the ground faster via gravity. Either way, you'll likely want to stay away from someone's dispersal area. Finally, at the top of the pyramid, individual risk factors are unique to every person. There are different thresholds of risk for every individual and family. This tension is palpable among different populations and highlighted by mainstream media. Some family members with pre-existing medical conditions, like asthma, are more vulnerable. Other family units may have grandparents living among them and need to consider their safety as well. What are some general preventive measures that churches can adopt? We can screen and keep symptomatic patients at home. We can protect vulnerable populations, such as the elderly and those with pre-existing medical conditions, and encourage social distancing at all times. Have individuals wear masks regularly, wash their hands, and use hand sanitizer frequently, limit surface contacts as much as possible, and finally, clean and disinfect church facilities thoroughly and often. Let's look a bit closer at two of the more controversial prevention measures: social distancing and the use of facial masks. This figure depicts the results of a meta-analysis looking at the use of face masks in preventing infection. Forest plots show adjusted estimates for the association of face mask use with viral infection caused by COVID-19, SARS-1, and MERS. On the x-axis is risk, or the odds of being infected. The dark horizontal line is the odds ratio of 1. Anything greater than 1 means there is increased odds of COVID transmission, or MERS or SARS, with a given exposure. An odd ratio or odds ratios less than 1 are protective. What we see is that face mask use is associated with less risk for viral infection. And this is particularly true for N95 masks, which not only protect others from being infected, but also the person wearing the mask. This graph shows the risk of infection with physical distance, the concept of social distancing. The bottom graph is easiest to interpret. Absolute risk is seen on the vertical axis, and on the horizontal axis, we see distance from others. It's really easy to appreciate the decreasing risk with increasing distance from others. Not surprising given the dispersal diagram. Well, now that we've covered general principles of prevention and safety, let's move on to the topic of reopening effectively. This is not meant to be exhaustive, as every church and situation is unique and requires its own calculus. However, I will highlight a few major ministry areas, recommendations, and principles. Let's start with Sunday worship within our sanctuaries and its various components. The welcoming team and greeters are key to directing traffic and implementing operational strategies. They can model and help encourage social distancing and other infection control practices. This presupposes contactless greetings and a paperless bulletin without the passing of Bibles, hymnals, communion trays, or tithing bags. Greeters can also screen symptomatic patients while protecting vulnerable populations. On the right, you see our church, New York Chinese Alliance, a poster that we've put together for infection control practices. What about praise? There is something sacred, inspiring, and uplifting about praise and worship. Psalm 151 reminds us of this. Praise the Lord, praise God in his sanctuary, praise him in his mighty heavens. Yet heartfelt and sustained singing can scatter droplets or aerosols much more than speaking. Does that mean that we forsake singing? Not necessarily. Perhaps we could consider simplifying the worship team by only having one vocalist instead of an entire chorus, or utilize glass partitions typically found in North America surrounding drum sets to protect those attending worship. Congregants wearing facial coverings while singing more softly is certainly beneficial to all. And as we think about sanctuaries and space, anticipate reconfiguring your seating. Limit attendance to a reasonable number to account for social distancing. It's roughly 20 to 25 people per 1,000 square feet. There are calculators out there on the web. Develop a strategy for the entry and exit of congregants that minimizes contact. If you have immovable pews bolted to the ground, you'll simply want to mark off spaces for use. But if you have portable chairs, you can consider reimagining the space in a way that invites congregants into the heart of worship while simultaneously adhering to social distancing practices. Tables can be utilized for families to enhance their worship. The speaker could even be centered in the middle to limit dead space. Large stages could provide extra seating, and clusters of seats could be interspersed among tables and chairs. There's really no limit to what you can imagine. Every sanctuary is unique, so reimagine space in a way that best suits your culture, context, and style of worship. As you do so, you may need to think about different service days and times to accommodate all congregants. For Asian American churches, there is a deeper level of complexity with overlapping language services and Sunday programs. Consider vulnerable populations and discourage intergenerational mixing if possible. Open windows and doors to allow for more ventilation. On the right, you see New York Chinese Alliance Church's 3-phase pandemic return plan. Contact tracing is important, especially with the likelihood of sporadic outbreaks within local communities. You'll want to try your best to track individuals while keeping records in case you need to notify families of potential exposure. Electronic systems like Breeze can help streamline this process for you. Well, we're not here to argue the theology behind transubstantiation or consubstantiation, yet pre-filled communion cups pose less risk than traditional passing of the elements. They are public health interventions that change the context of risk for all congregants without conscious decisions made by individuals. Our church will set these cups in front of each chair before service, further limiting contact and reducing risk. Be careful though. Expired packets are heard to congeal quickly. You may want to monitor the cups lest you serve communion wafers and jelly. What about small groups? In general, small group activities like Sunday school, fellowship activities, and discipleship groups are lower risk than congregational worship. However, there is increasing risk with larger numbers, increased time together, the sharing of food, and intergenerational mixing. Special populations like the elderly, children's ministry, and nursery require specific planning to mitigate risks, as well as those with pre-existing conditions. What about bathrooms? Bathrooms are some of the most highly trafficked areas within a church. Look at this picture of a church bathroom. What are some of the inherent risks that you can identify? If you like, please type them into the chat. I will give a few moments. Okay, it looks like I'm having a little bit trouble looking at the chat, but I will just comment based on some of the things that I've seen before. Actually, okay, here we go. I see it now. Wonderful. A lot of interaction today. So that is exactly right. Somebody mentioned soap dispensers, and then plants and paper towel holders and door handles. That is exactly right. We can't exactly tell if the soap dispenser is automatic, but certainly the faucet handles are great potential for transmission as they will be repeatedly touched. And that's right in terms of the stalls. to open and close the stalls, as well as the door entering the bathroom that would be potentially repeated exposure. Another gentleman has mentioned confined space and recirculated air. That's exactly right. You will not want to have 3 people washing their hands at the same time, and also another group of people waiting in line right after them, because we will not be able to ensure social distancing in that regards. So for a bathroom of this size, you may want to limit the number of individuals within that restroom. Somebody else mentioned the air blower hand dryer. That's exactly correct. In fact, we will like to turn off that hand dryer. While it works wonderfully in regular conditions and saves trees, by turning on that air dryer, you are recirculating those aerosol particles or droplets into the air as you breathe them. Tissue box and flushing toilets. That is a very prescient comment. So you do not see the toilets, but if you open the stall, when you flush the commode, you essentially aerosolize viral particles into the air. Now, studies have shown that feces do carry the coronavirus, SARS-CoV-2 virus, although to my knowledge, there has not been active transmission that is fecal oral of yet. But just to keep in mind that when you do flush the toilet, you do aerosolize particles. I think that is a much lower risk compared to the comments in the beginning, such as the air dryer, social distancing, touching of contact surfaces over and over again. But it's just something to keep in mind. Finally, let's think a little bit about reopening biblically for a few moments. There is no black and white when it comes to reopening the church. I believe we must balance the theological tension within shades of gray. This includes weighing the ministry of presence with the freedom of sacrifice, both essential to cruciform faith. The freedom of sacrifice reverberates throughout the Gospels. Mark 12:31 echoes the love of neighbor seen in Leviticus 19:18. Choosing to meet together in Christ's name while endangering our elders' health may place us in the same position as the people Jesus condemns in Mark 7:11 for dedicating property to God that our parents need for their support. And yet, the greatest sacrifice is seen at the foot of the cross, modeled for us to embrace. On the other side of the scale lies the ministry of presence. The author of Hebrews exhorts us not to give up gathering together in Hebrews 10:23. And Luke points out the centrality of meeting together in his account of the early church. In Acts 2:42, he gives witness to the actions of this church who devoted themselves to the apostles' teaching and the fellowship, to the breaking of bread and prayers. In New Testament times, leprosy was among the most feared and devastating of illnesses. Lepers were typically quarantined and ostracized by the public. Yet Jesus did not run from people with leprosy. He reached out his hand to heal instead. He could have healed by word alone and avoided contact, but instead he extended love through the power of human touch. With that leper, Jesus risked what others would have feared as both contamination and ritual defilement. And like Jesus, we should not necessarily be afraid of those who are sick with COVID-19. Sometimes we are called to care for them in creative ways. While grappling with this tension, let us not forget about the sovereignty of God. He is the blessed and only sovereign, the King of Kings and Lord of Lords. God reigns over pandemics, plagues, and pestilence. Paul describes him as over all and through all and in all. He is actively involved in sustaining all of creation and has ordained this time and tension for each of us to grapple with. Finally, the sociologist Rodney Stark argues that the explosive growth of Christianity was secondary to Christians staying in urban areas during the epidemics of 165 and 251, ministering and caring for the sick. Sound familiar? Today we have that same opportunity. The word pandemic comes from the Greek pandemos, with pan meaning everyone and demos, population. Every individual in the world is affected by COVID-19 to some extent. Therefore, every individual in the world has a unique opportunity to experience the good news of the gospel. In a time of two epidemics, which killed up to a third of the whole population of the Roman Empire each time, the Christian message of redemption through sacrifice offered a more satisfactory explanation of why bad things happen to innocent people. Further, the tighter social cohesion and mutual help made them better able to cope with the disasters, leaving them fewer casualties than the general population. This would later be attractive to outsiders who would then be converted to Christianity. Lastly, the epidemics left many non-Christians with a reduced number of interpersonal bonds, making the forming of new ones both necessary and easier. During the early pandemics, Dionysius once wrote, "Most of our brother Christians showed unbounded love and loyalty, never sparing themselves and thinking only of one another. Heedless of danger, they took charge of the sick, attending to their every need and ministering to them in Christ, and with them departed this life serenely happy, for they were infected by others with the disease, drawing on themselves the sickness of their neighbors and cheerfully accepting their pains. Many, in nursing and curing others, transferred their death to themselves and died in their stead." May we model the acts of the early Christians, that our generation would also experience the sure and steadfast anchor of the soul, a hope that enters beyond the veil.
Thank you very much, Stephen. We've been listening to the Reverend Dr. Stephen Coe addressing the question of reopening church safely, effectively, and biblically. And thank you, Stephen, for a wonderfully comprehensive presentation that we've just heard. If you have just joined us during the webinar, then we're now moving into a time of question and answer. And if you have a question for Dr. Coe, if you can put that into the Q&A box at the bottom of your screen, you'll see the number 5 is showing there already because there are 5 questions asked. So if you just type your questions into there, not into the chat box, which is for you to talk to each other. So put them into Q&A. If you're wanting to hear the answers to these questions in another language, then we have 7 translators with us today. And if you click the interpretation icon along the bottom as well, it will bring up 7 languages. In terms of French, Spanish, Portuguese, Russian, and Mandarin, you just click the language. But the other 2 buttons, the German button is actually an Arabic translation. And on the Korean button, you can hear a Bahasa translation. So 7 languages available today. So, Dr. Coe, we now move on to the questions, and And as you read these questions, others, you can upvote them. So if you see one that you particularly like to be asked, then upvote it, so it will be more likely to be asked before we run out of time at 3 o'clock BST. So the first question, Stephen, some older folk, 75 plus, have said it's unlikely they will ever risk returning to a church service. And how do we encourage them to return, or should we be completely changing how we minister to and do church with this age group?
Yeah, that's a wonderful question. And our church in particular has a rather large population of elderly. And before COVID-19, we had a thriving elderly fellowship on Thursday mornings. We typically have about 100 elderly over the age of 65 enjoying fellowship, a meal and luncheon, and also the hearing of the word. And unfortunately, we've had to shut that down secondary to COVID-19. But while these individuals are at higher risk, Peter, if you look at the stats, if you're 60 to 70, you could have anywhere between a 3 to 5% mortality rate. If you're 70 to 80, it could be anywhere between 7 to 10%. And if you are over 80, the risk could be above 15% mortality. So I am very concerned about the elderly and grandparents among us. But I also realize that being home alone and without support, as well as the ministry of presence, they may suffer as well. So I believe it's very important to continue ministering to the elderly in creative ways. Some people say you can't teach an old dog new tricks. I don't believe that's true, because 90% of our elderly fellowship is now able to log into Zoom and to hear those same messages online and be exhorted. Our particular church has started an elderly outreach ministry where we deliver food, we meet the felt needs of the elderly, and we continue to do this ministry. So I think you have to be creative. I know we have different countries and regions of the world, and the context is different, but be creative and minister and love on the elderly and also other vulnerable populations as well.
Thank you. Do you have any specific recommendation for improving safety of children's ministries?
Yeah, that's actually a whole lecture on itself, Peter. But in regards to children's ministry, if I could differentiate a few major areas. Number one, the elderly are able to understand concepts of social distancing, easily wear masks, and sort of follow directions, unless you're suffering from dementia, etc. But when you go to the other side of the spectrum, in regards to children's ministry, in particular infants and toddlers, let's face it, if you are in the operational phase of development, a toddler is not going to be able to understand the concept of social distancing, nor stay away from other toddlers. Everyone that has children understands that they'll be touching everything in sight, as well as hugging, the caretakers. So, ministry that is targeted at nurseries, toddlers, and children really has to be very nuanced and carefully thought out. What's very interesting with COVID-19, compared to, other respiratory viruses such as influenza, flu, is that typically you have a U-shaped curve where you have the most vulnerable, the elderly, and, the young that are most effective. But as most people know at this point, one side of the U is sort of missing. You can have disease transmission among children, but not to the extent of morbidity and mortality for, the elderly population. There have been, some cases of sort of this inflammatory disorder, since we have physicians on the line, but that's sort of a nuance. So what I would say, Peter, is that you have to really carefully plan, not only for aspects like social distancing, how you use your space and partition, but then also, how are you going to keep, the rest of the congregation safe as well? And that's why I didn't go over our phased approach, which is 3 phases. But the elderly and children's ministry are really going to not start into phase 3 for our church in particular. We just want to make sure that we're protecting the community. But I will, push you over to the CDC guidelines. There are wonderful resources. One of my good friends is, a director of science there, looks over a lot of these guidelines, and there's, wonderful resources. In particular, there's overlap, for children's ministries with typical schools and nursery. So you can not only go to sort of the church section, but also, how do you run a nursery? It's the same thing, right?
On the ministry side of that, how then do we address the ministry needs of children between phase 1 and phase 3 when they're not able to rejoin?
Peter, personally, as a pastor, I believe that God has put COVID-19 among us for a reason and a purpose. If you look at some of the Hebrew, there's a Hebrew word that means shake. And sometimes he uses pandemics and plagues to shake us so that we may draw closer to him. And I believe that this is a time for families to stand. That, for so many years in North America, children's ministry and youth ministry was, let's drop off our kids in the church and let them take care of everything. But now it's a time for families to stand in the gap, to do worship at home, to minister to our children and disciple them as Jesus exhorted us, and to do so without exasperating them. So that's number 1 a priori. But number 2, as churches and pastors and children's ministers and youth pastors, we could also develop creative paradigms. Let's face it, our youth and younger children love to use iPads and iPhones. In fact, they may use them better than you and I, Peter. And so there's a lot of creative ways that you can engage children. And I've seen so many different creative ways of online ministry and forum, utilizing cartoons, interaction, and the kids really love it. That's the truth of the matter.
Thank you. A question from Mark now. How do I convince my pastoral staff, says Mark, that everyone should be wearing a mask inside the church, especially with singing?
Yeah, that's a wonderful question, and partly why I put those 2 figures, because it's a really controversial issue. And unfortunately, we're not here to talk politics today, but it's become, obviously a little bit politicized around the globe. But, as healthcare providers and scientists and researchers here, the best way to go about this is really the data. You can start with the studies that I showed, a large meta-analysis. It's not just one study. It's not, a case study. It's looking at clinical trials and randomized trials. And, you need to sit down with your pastor. And, the second point, beyond data is looking at the gospel, right? So coming at it at a theological angle where you're balancing, as I was mentioning, the ministry of presence, which is so important to pastors, but then also the sacrifice of loving your neighbor. So number 1, look at it with empirical data, research that's been published, and number 2, with gospel lens as well.
Great. A number of people are asking about the presentation, and we will write to everyone who's come to the seminar afterwards and send you a PDF copy of the presentation, which you can use. And also this presentation will be up live on YouTube early next week. Question from South Africa now from Jay, who asks, how advisable is it to return to church at the peak of the pandemic in South Africa?
Yeah, I think this is the reason I sort of, put together that pyramid for everyone. The pyramid sort of, if I will, the beauty of kind of considering risk factors within a pyramid is that at the base of the pyramid is exactly this question, right? The coronavirus activity within a specific region, locale, or even country. That really undergirds all of the risk factors. if you don't have active transmission, let's take it at a country-to-country basis, right? If you compare South Africa to the United States, maybe to Italy, and put in Taiwan right there, each one is very different in terms of transmission and incidence. Taiwan really is doing pretty well. And so it's really a wonderful time to restart and reopen. But, if you take a page out of sports, and we look at Major League Baseball, the Miami Marlins recently had almost 17 to 20 people on their team infected. To me, that's not very surprising, because in the last few weeks, we've had over 10,000 cases a day in Florida, right? So you really have to consider, and I'm glad the gentleman from South Africa mentioned that, what is underlying the transmission, so that doesn't only go for the reopening of churches, right? It's also, a phased approach for the community, whether it's restaurants, it's, your local gym, other activities. And I believe every country and every state and region typically has, phased approaches. You can sort of argue the merits of when you move from phase to phase, but, the base of my pyramid is arguing that you have to base it on active transmission. And so, the $30,000 question is, what point in time do you shut that down, right? And I think there's a lot of nuance to that. If you're in a community with a lot, higher population density of elderly, it's a lot different than if you're in a community, generally with, generation Y and Z.
Sure, and I guess every country will have its own national guidelines as well, which might be overcautious or over liberal. There's a follow-up question from Hannah here on that. What's your opinion on when churches should return based on a percentage of transmission in your community? Should it be below a certain percentage, or is that too nuanced to say?
Yeah, I'd rather not put a number on it, but what I will do is base it on your question, which is, where is the community at that point in time within their reopening plans? Let's take New York State, for example. There's a four-phased approach to reopening. Phase one, all the way to phase four, which is more museums, sort of attractional facilities, right? And so, certainly, if you were to base it on New York City and New York State, it may be better for a church to be in the phase for reopening, which is similar to the other type of endeavors, right? So, for New York State, that's kind of the latter phases. Although, the nuance for this, Peter, is the fact that, as I mentioned, even in the triangle or pyramid, every ministry activity is not necessarily equal, right? So if you have a large worship service with 1,000 people, that's far greater risk than a small group activity with 6 or 7 of the same generation that know each other very well. Does that make sense? And so I don't think you should necessarily base it on a percentage of incidence or even prevalence, but rather, how is the community doing and what church ministries? So you may want to, similar to our church, do a phased approach. And that's exactly what we're doing. And, our church is a little bit different because it's a lot of different languages and ethnicities. But, sometimes you may want to start, and this is where you can look at some other guidelines with just small group activities and then work your way up.
And just on that, Stephen, someone has asked here if you could just quickly outline your phase 1, 2, and 3 for us that you're applying in your own church.
Yeah, I'm happy to do so, just with a caveat that we are very unique, because of the fact we have 3 languages and a lot of overlap between, it's not just one children's service or youth, but it's like an overlap, right? With number 1 and number 2. And so in general, if I was, just in a church with one language, 1 or 2 services, our approach would have been very different. I would have started with small groups first. But our phase one is essentially just starting our worship service, and essentially giving more time in between the services, and then obviously doing the things in the presentation, which is social distancing. So we have a few different sanctuaries. Our biggest one seats, I think mid 300s, maybe call it 350. And then we have several services, right? So within that, we've already calculated how many seats we can have there, and it's a fraction of, the 350, given the rule I gave you guys, it's roughly 20 to 25 per 1,000 square feet, right? And so we're incorporating social distancing, we're using the masks, we're protecting in terms of singing and, the way we do communion I explained before. So with that being said, that's phase one. And then we're going to allow that to move forward for, some time. The pastors will have already come back to church. And then gradually phase two later on would then incorporate this sort of nuanced milieu that we have, in between services with different services, right? So we would then begin starting to do the Sunday schools, the small group activities, the prayer meetings, et cetera, within phase two. There's a lot more nuance, obviously, underneath that, but this is a 30,000 foot view. And then it wouldn't be until phase three, which, likely is going to be, 2021 sometime there, that we would start incorporating elderly. And then, your previous question about children's ministry. What I will say is by that time, the prayer is that, some of these vaccines that are now in phase three clinical trials will be, ready to go. Although, the ethics of vaccination and who receives it is a different issue.
Sure. A question from Mike now. Mike, what is your opinion regarding mask wearing during non-singing times of a worship service, both indoors and outdoors?
Yeah, in general, I am a pretty big proponent of facial masks, especially indoors. If you do have a large outdoor arena or area, a grassy field, it's a little bit different. It's easy to social distance. You have a lot of good airflow. So you can maybe make the argument, right, that if you social distance well, it's a little bit less risk. But, as an epidemiologist, I look at risk. And the risk is certainly much greater if you're in an enclosed space, which is typically, sanctuaries. So, why not do the social distancing and the wearing of masks? Really you're trying to protect others, especially if you, have a N95 type of mask. It's like, I showed before with the aerosols, you see that colorful diagram, you cough, those aerosols could be in front of you for several hours. Even if you're not there in the room, the aerosols could still be in the air. I didn't maybe differentiate well, but respiratory aerosols are different than respiratory droplets. The droplets are heavier, more liquid laden, and they fall to the ground quicker. The aerosols just sort of linger in the air. So I'm definitely a big proponent of that. Obviously, if you think about the pyramid we talked about, certain areas matter more, right? If you have active transmission in your community, it's a really good idea to have the masks, because you're protecting the vulnerable populations.
Now, this will probably be our final question, and it's maybe a challenging one. Someone is asking here, what do we say to people who are Christians who believe that God offers protection on the basis of Psalms like 91 or 121, where it talks about God preventing us from harm, and that therefore we don't need to take preventive measures? Or perhaps even people who just feel that they're not really trusting God if they are taking preventive measures of the sort that you've been talking about. So just some words of encouragement and also advice about how to handle these sort of questions, which inevitably will come up.
Yeah, absolutely. It's a very rich theological question. And the truth of the matter is, in Matthew 9:35, Jesus goes through the cities and towns and He preaches, teaches, and he heals. He never separates his spiritual preaching and teaching from the ministry of healing. Really, whether it's the healing of a leper, the healing of a blind man, or a lady that's bleeding out, likely with menorrhagia or metromenorrhagia, there is always healing. But if you look at somebody that I respect so much, Dr. Francis Collins, who founded BioLogos, and is just a phenomenal researcher, but also man of God. There's never really been a point in time where there wasn't a mixing of the biblical wisdom, but also the wisdom that God has given us. In fact, I just wrote a chapter. There's a book on theology of disease that's coming out in 2021. But in it, I looked at sort of the science of epidemiology and public health in the Old Testament, and it is amazing to see even that the first public health guidelines, what they are, Peter? It's Leviticus. And even in Leviticus, there's a basic understanding of epidemiology, isolating an organism, even if you didn't know what it was, looking at dynamics of transmission. They were quarantining and isolating, in Leviticus before the term quarantine, which comes from the Italian. I know we have Italian interpreters here. Quarantino, which means 40 days. That didn't come about until the 15th or 16th century. But early Christians were already doing that based on science. And so, my answer is similar to before, that, for Christians, one and the other, faith and science, it's not one or the other. It's the two together, and having that nuanced and loving conversation that encourages individuals to sit down. That's the way to go. There's no guilt, there's no shame, but there's only the fidelity of love, Peter.
That's a great answer, Stephen. And as you say, part of God's protection for his people was in these very wise guidelines about quarantine and isolation, which go back a long way. And of course, the Lord himself, when tempted to jump off the temple on the same basis, didn't do it. So it's balancing wisdom, or as you're saying, balancing ministry with the freedom of ministry with the duty of love. So thank you very much for bringing that to us. I'm afraid that that's all we've got time for today. We do have more questions coming. And if you've been listening to the seminar on Zoom and have enrolled for it, then we will write to you in the next few days. We'll send you a copy of the presentation in PDF format that you can use. And we'll also make available a list of the questions that have been asked, including those that we didn't have time to answer. And our next webinar will be next week on the 6th of August, again on Thursday at the same time. And Ted Lancaster will be talking to us about the long-term impacts on global health of the COVID epidemic. So it just remains for me to say thank you very much, Reverend Dr. Stephen Coe, for joining us today and enlightening us and answering our questions so well. And thank you very much to our 7 translators for all your hard work behind the scenes. And just a notice to you, Stephen, and the translators, if we could just meet briefly after this meeting, we'll send you another Zoom link for that for about 10 minutes or so, just to debrief. So thank you very much, everyone, for joining us again, either on Facebook or on Zoom here for the ICMDA webinars. We'll see you again, hopefully next week. May God bless you and keep you safe in the meantime. Thank you.